So what I need you to do, guys, what I need you to do, I need you to remember the chest pain in terms of elaboration. We spoke yesterday about the ACS and the angina, and we spoke that the angina comes in episodes, and the ACS usually is continuous pain which happened in the past, not in the very, no, just like maybe a few hours ago, and it was even worse. Its score is even much higher than angina, and the pain is not relieved by rest, and it's not elicited by physical activity. While the angina comes by activity, the angina, by the way, anyone here is having problem with the voice? Because some people have been messaging me and there is problem with the voice. Dr. Anika, I think it's from your earpiece. I think so. I think it's from your earpiece. So, okay, perfect. Um, Today we will start with one of the stations, which is pulmonary embolism. Pulmonary embolism, I don't know why some people are having problems with this station. Actually, they are absolutely right to have problems. Why? I will tell you why. Because simply this station, you do not usually, sorry, you need something strong to diagnose pulmonary embolism. Guys, I'm sorry, give me 1 minute. Give me 1 minute because I need to solve it for some people. Some people are having problems with the voice. Okay, I'm muting myself. I'm sorry, guys, for the interruption. Um, the thing is that today we are starting with the pulmonary embolism. Please, if there's any problem with the voice, guys, do let me know instantly. Okay. Anyway, I told you again that today's session will be recorded due to the problem with the connection, with my problems. But next sessions will not be. Okay. The people, yes, okay. So the people who told me that they are not attending are Dr. Fumzi, and Dr. Samia. Today we'll start with the pulmonary embolism. Okay, for the pulmonary embolism, I told you yesterday how to elaborate any chest pain, right? For the elaboration of the chest pain, please make sure that you do not forget about the character and the for the character and for the relieving and aggravating factors, and definitely the radiation. One thing is that there are two scenarios for the pulmonary embolism. It's either presented with shortness of breath or presented with something else, like chest pain. But the good news is that when it comes as chest pain, it comes as differential diagnosis station. For example, the examiner will tell you what is your differential diagnosis, not what is your diagnosis. Why? Because simply pulmonary embolism cannot be clinical diagnosis. Pulmonary embolism, like any other chest complaint or any cardiovascular complaint, it needs to be confirmed with further investigations. Which investigations, by the way, guys? Usually here, the good thing is that in PLAB2, to have a clue to the pulmonary embolism, they will give you one risk factor. And this factor could be either a major surgery, which happened a few days ago, could be DVT, could be history of malignancy, and could be history of oral contraceptive pills, could be also family history of blood clots. And the good news is that there could be something which in Wells score, which tells or which say that the symptoms are suggestive of pulmonary embolism and nothing else. So usually the patient is here moderate to high risk. So usually you will not need to do the D-dimer. You will usually go to the CTPA, CT pulmonary angiography. So here in this station in the pulmonary embolism, what you will find, I will tell you what to find. You will find in this case that the patient is coming with shortness of breath. Definitely this patient can be coming to the A&E. Okay, why? Because this patient simply is having shortness of breath. Okay, shortness of breath here is the presentation. The main presentation, guys, here is shortness of breath. Do not always forget that. Presentation in pulmonary embolism, if you want to diagnose pulmonary embolism, make sure that the presentation is shortness of breath. What you will find, this shortness of breath could be started maybe a few hours ago, up to 2 days. So the patient will give you history of pulmonary embolism, which started a few hours ago, up to 10 or a few days ago. Okay? Okay, actually it could be aggravated and it could be increased. So what does this mean? This means that simply in this station in the pulmonary embolism, the shortness of breath is increasing, and the shortness of breath usually it worsens maybe on any activity. So the patient is presented with shortness of breath, which increases on activity. What else? The patient is having usually chest pain. What type of chest pain? You know what is the type of chest pain, Dr. Zaid? Can you tell me what could be the type of the chest pain which is in pulmonary embolism? Like character?
Yeah, sharp, pleuritic, lateral.
Don't say pleuritic, just say sharp pain. Sharp pain is right. Stabbing pain is right as well. It can happen in any form actually. So the good news is that the chest pain is not characteristic to the pulmonary embolism. It can happen, okay, usually the patient will tell you it is stabbing or sharp pain. This is what the patient will tell you. Okay. So now you're having shortness of breath, which increases on physical activity, and it's here since few days. And as well, you're having chest pain, which is in the central chest. Always mind that the chest pain is in the central chest. Okay? Why? Because some people may confuse it with other complaints. Okay, in the ACS, guys, usually, okay, it is in central chest as well, but it is referred, usually. There is radiation to somewhere else. But pulmonary embolism, usually there is no radiation. And one very important thing, which happened recently in one of the stations, the patient will give you this chest pain which worsens on deep breath. Worsens on deep breath means that usually this complaint is related to something in the lungs. You know why? Because when you take a breath deep, simply, here comes a problem when it is associated with the lung. We all know that pulmonary embolism is due to the circulation in the lung. Okay, okay. So, chest pain which increases on deep breath as well. Okay, I mean, I'm picking the most important points for each complaint. And the score definitely would be high score, at least 6. What else could be the other associating symptoms to this complaint? We spoke yesterday about the shortness of breath and the chest pain, if I'm not mistaken, right? The associating symptoms to the shortness of breath and chest pain could be, number 1, sweating. Number 2, which is very important, cough. If anyone forgets about the cough, he or she is in trouble. Okay? Why they are in trouble? Because the cough is one of the differentials that you rule out by one question, which is chest infection. So do not forget to ask about the cough. Number 1, cough. Number 2, fever. Number 3, which is very important, nausea and vomiting as well. What can I not miss in this situation? Do not miss to ask about the chest pain. Do not miss to ask about the cough and the fever. Why? The cough sometimes can be positive. You know, sometimes the patient is having cough with blood in the pulmonary embolism. So usually they would not give you this finding, because if they give you this finding, you would know that it's pulmonary embolism. But they need you to be a little bit, they need it to be a little bit twisted. So do not forget to mention about the cough and the fever. Okay? Dr. Masih, what are your differentials here? And how to ask about them, one question for each.
Differentials would be pericarditis.
Okay, perfect. You already knew about the pericarditis from the criteria or from the description of the chest pain. The pericarditis is usually worsened on
bending forward, it is relieved.
okay, and worsen actually as well. It can be worsened on physical activity. Okay,
Yeah.
so you already ruled out pericarditis from the elaboration of the presenting complaint. Okay, that's why I always stress on elaborating the presenting complaint very well. Even if you forget to miss DDs, it's fine, because from the elaboration of the presenting complaint, you already ruled out differentials. Okay? Okay. So, Dr. Masih, tell me, what are your differentials apart from the pulmonary embolism here? By the way, and apart from the ACS, because the ACS is also ruled out through elaboration of the chest pain.
Maybe edema, pulmonary edema.
Not really. Okay, not really. You know why. But ask me one more thing, or ask me two more things. We already ruled out number 1, pneumonia, by asking about the fever, right? Hello? Hello?
Hello.
Can you hear me?
Yeah.
Okay, so I asked you. We already ruled out pneumonia by asking about the pulmonary, by asking about fever, right? What else could be ruled out, Dr. Masih? Trauma, Dr. Masih. Trauma, Dr. Masih.
Trauma.
This is very simple. Why? Because there is one infection in which, by the way, I forgot to include it today, and I will include it. I include the chest pain infection, or this chest trauma station. It's very easy station. I will include it instead of one of the today's stations. Okay, I will choose. It is a combined station actually, but it's very easy, and it must be discussed today. So, Dr. Masih, your differentials here are trauma, right?
Sure.
Okay. What else you can okay, so this is your differential diagnosis, trauma and pneumonia, because you rule out the other things from the presenting complaint, right? Right. What is the most important thing you ask in the past medical history? For example, what could happen recently that can lead to pulmonary embolism?
Surgery.
Perfect. What else?
Recent travel.
DVT. Yes, DVT.
Yeah, DVT.
DVT is very important. So do not forget to ask, how was your health recently? And in the recent health, you would ask, by the way, I told you Q1, question 1 is the previous episodes. Question 2 is recent health. Question 3 is the medical conditions. Question 4 is medications. Question 5 is allergy. And question 6 is hospital stay and surgery. You can combine them in one question. And question 8 is usually family history, which is still important in this stage. So, Dr. Masih, in the past medical history, there are 3 points never to miss. Okay? Number 1, the DVT. You will ask the patient, how was their health recently? Did you have any redness or swelling in your legs? What about any heart racing? Why heart racing? Because usually the heart racing is associated with the pulmonary embolism as well. Okay, so redness and swelling in the leg muscle. Okay, this is number 1. So we ruled out the DVT here. So in the medical conditions, what do you think you should ask in the medical conditions? I need just 2 or 3 questions in medical conditions.
Have you been diagnosed with any heart-related disease?
Perfect. Hypertension, heart-related disease, any previous cancer or malignancy. Just say any previous malignancy or any previous tumor. Very important. Okay, I need one more thing as well. Hospital stay, very important, and recent surgery. Why? Because these things are making the patient bedridden, which makes him develop the risk of being, which makes him under the risk of developing pulmonary embolism. Okay, so hospital stay and recent surgery. Number 8, question number 8. Don't you think that the family history is important here as well?
Yes.
You know why? Because actually, if there is a family history of blood clot, the blood clots usually runs in family. This means that she's at risk as well of developing blood clots. And actually, she's having one of her relatives or her mother, I think, she was developing blood clot in her legs. So from the history, we picked up 4 points. Number 1, DVT in the recent health. Number 2, medical conditions, hypertension, any heart problem, any cancer. Number 3, the recent hospital stay and surgery. Number 4, the family history. These are the 4 important points in the past medical history. Remember, this patient is female patient, Dr. Massi. So what you need to ask?
Sorry,
Female patient.
you can ask about the 4 Ps.
Perfect. 4 Ps are very important. Okay? 4 Ps here, never forget about them. Why? You will know right now why. Because this patient is taking OCPs, as just Dr. Yasmin and Dr. Ela just mentioned. The patient is taking oral contraceptive pills since 3 years. And oral contraceptive pills are one of the risk factors for pulmonary embolism or blood clots. So please never forget about the OCPs in this station. In the lifestyle, you can ask about the whole lifestyle, like any cardiovascular problem. Lifestyle is very relevant when you are suspecting any cardiovascular problem. What about one more question I need to ask? One more question, or 2 more questions actually. Dr. Messi, what do you
Travel.
think? Yes, perfect. Travel history and the long distance travel, or the short travel or short flights. Okay. I mean, for example, if the patient tells you, I went, for example, you are taking the exam in Manchester. If the patient tells you, oh, doctor, I went to Liverpool recently. I mean, do not ask the patient, have you traveled recently? She will tell you, yes, I went to Liverpool. You know, Liverpool is 45 minutes from Manchester or 30 minutes. So just ask, and did you take any flight? Always be specific, because the travel history is maybe domestic and maybe international travel. So ask, yes, this can happen. This is ridiculous, but ask us. So, and you can be specific, have you traveled recently outside UK? Why? Because it means long distance flight, not any travel. Okay? So ask this question, travel and recent flight. What are your differentials here? As I said, ACS could be pulmonary embolism. Dr. Yemi, actually you will ask about the period, the pregnancy, and the pills. For the period, how was your periods recently? Are they regular? Any problem? No. For the pregnancy, have you ever been pregnant before? She will tell you yes 2 times. And when was that? This is the pregnancy. Most probably or most commonly focus on the pills. Why? Because the pills actually, she has taken oral contraceptive pills since the past 3 years. And she's taking them regularly. So this means that she's at high risk of developing blood clot. Okay? What are your differentials here? As we said, well, your differentials could be ACS, could be pneumonia, and could be as well maybe asthma. Why asthma? Because the patient is having shortness of breath and cough. Okay? You already picked it up, but usually it's not asthma. Why? Why it's not asthma? Because the chest pain is severe. This chest pain does not match with the asthma. But anyway, the most 2 relevant DDs are pneumonia and ACS and trauma, as we asked. You will do all the examinations, but most importantly, focus on the vitals. One interesting fact in this station is that if you do not mention, I need to check your vitals, including your oxygen saturation, your blood pressure, your heart rate and your breathing rate, the examiner may not respond to you in terms of the O2 saturation. So please mention everything you're asking about. That's why I always stress when asking about the vitals in details. Dr. Kashi,
Excuse me, brother.
Yeah.
Brother, in the vital section, do we need to mention all the vitals, or if you just say that I'm going to take your vitals now, that will include everything?
Please always mention it, because some examiners are I'm sorry to tell you, but some examiners are sleeping. They are just waiting for one word from you. If you do not mention the word oxygen saturation, he will not reply to you. Okay, this is not a rule, but it happens many times. And you will see in next stations and some other stations as well, the examiner, by the way, it happened to me. It happened to me in the obstructive sleep apnea. I told the patient I need to do this and this and this and that and everything. And I said, even general physical examination, I told the patient I need to check your weight and your height. But just because I did not say I need to measure your weight in relationship to your height, the examiner did not give me the BMI. But I realized this later. I realized it when I reached to the investigations. I told him, oh, I'm sorry, I need also to take your weight in relationship to your height. The examiner right now responded to me and he told me the BMI is 32. Okay? So that's why I always stress on verbalizing everything. They need you to know, to be specific and to determine what you are looking for. Okay, so the vitals here will show you usually a high respiratory rate and low oxygen saturation. This means that there is real problem with the breathing, or this real problem with the oxygen saturation. So I would like to do some investigations. The examiner usually will not answer you or will not tell you anything. The patient will ask you, doctor, what's going on? You will tell him that I'm suspecting, or from my assessment, seems that you're having a problem we call pulmonary embolism. What is this, doctor? It is a problem due to the disruption of the blood flow in the big artery supplying your lung. That's why you are having this shortness of breath and this pain in your chest. Embolism means disruption or obstruction. Embolism happens in the artery, so it happens in the artery on the big blood vessel supplying your lung. That's why you are having this shortness of breath. Oh, doctor, what are you going to do for me? Right now, number one, this is an emergency, Dr. Masih, right? It's considered to be emergency. So I need to keep him in the hospital right now. I need also to ask my senior to come and review him. But the patient usually does not want to stay in hospital. What will you say, Dr. Masih, if the patient tells you, I do not want to stay in hospital? What will you say?
Okay. I'm gonna say I do not wish to worry you too much, but it is really important for you to
Dr.
stay in the
Masih,
hospital.
now the file is back again.
No, I may
Huh?
why?
Yes, definitely. If you do not
Okay.
want to, if you want to spare your money, please do not make this mistake again. Okay.
Okay.
So this patient will tell you, doctor, I'm having, for example, I'm having to go and watch a match today. This patient will tell you something, maybe something strange, like, for example, I have to pick up my children from school right now. So simply, you can tell her that I can see it can be quite frustrating, but we are going to arrange a carer for you if you wish. Or simply ask her, don't you have anyone else to look after them for a while? She will usually tell you, yes, doctor, my sister can look after them. See, it's very simple. And by the way, she's already having the solution, but she wants you to explore it by your way. So please ask why. Okay, now she will tell you, okay, doctor, I can ask someone to come and pick them. But doctor, it's really frustrating. You will tell her, yes, it's frustrating, but we need to keep you in the hospital because we need to give you the best possible treatment. So we need to do further investigation for you. And we need to do further investigation for you. What is the treatment here? Usually the treatment here in the pulmonary embolism, number one, you will do some investigations. Which investigations? The initial investigations. The investigations are bloods and ECG and chest X-ray. So blood and ECG and chest X-ray. The initials, after which you are going to give her blood thinner. Which blood thinner you do not need to mention. Usually it's heparin, but why do you need to mention? Just say I need to give you blood thinner to dissolve this blood clots in your lung. After which we need to refer you to specialists. What will the specialist do? The specialist will do a procedure to look inside your lung, to look in the blood vessel in your lung, which is the CTPA. Okay, to see if there's any obstruction. So the specialist will do the CTPA to see if there's any obstruction. Doctor, I don't want it to happen. May I know why? Because doctor, it's too much. I do not want to undergo these procedures. Now you will tell her that it's important because we need to confirm your diagnosis to start your definitive treatment after it. Because you know, sometimes this problem can be having some complications, which can be life-threatening sometimes. Okay, doctor, so how are you going to treat me? Simply treatment here, as I said. Treatment here, we will keep here, and you will give her oxygen because her oxygen saturation was low. Number 2, you need to give her blood thinner, as we said. And after confirming by the CTPA, you will continue the blood thinner for 5 days up to 1 week. So the blood thinner initially, once suspected. After suspected, refer to the CTPA. After CTPA and confirm, continue the blood thinner for 5 days or 1 week. After this, she will continue other oral blood thinners, which is warfarin, for 3 months at least. Okay? Okay. So, this is the management of the pulmonary embolism. Oxygen for shortness of breath, blood thinner injection, number 2. Number 3, refer to specialist. Okay? And what will the specialist do? He will do the CTPA, okay, to confirm diagnosis, and they will give you, or they will even continue on the blood thinner injection for 5 days to 1 week. And after this, actually, you will continue or to take blood thinner tablets for 3 months. So 3 months, blood thinner tablets. This is the management. So to sum up the management again, number 1, you will disclose. Number 2, you will explain. Number 3, you will admit in the hospital because you need to do further investigations or initial investigations, sorry, including chest X-ray and ECG. Okay, and you need to start heart treatment. What is the treatment? Symptomatic oxygen, number 1, and number 2, you need to give the patient blood thinner injection. After the blood thinner injection, refer to specialist to do CTPA to confirm. And after CTPA, you will do blood thinner for 5 or more days or 1 week at least. After that, the blood thinner will be continued for 3 months, but in an oral form. This is a pulmonary embolism. This is one of the most boring stages. Seriously, I do not like it. But anyway, it's easy. But it's boring because it's confusing. You know, it's really like it's. You do not give painkiller here usually, because the chest pain is. Excuse me. Wait a minute. I'm just closing something. Okay, Dr. Murad, you can take 2 minutes break. It's fine. No painkiller. The blood tests initial. Okay, I'll tell you the initial blood tests are usually the full blood count and sugar level and liver and kidney function test and thyroid. And yes, you need to do the initial blood tests here because one of them is a clotting. No painkiller in this station, and no painkiller in the pulmonary embolism. Why? Why? Because actually the pain is due to the clot. And once you dissolve the clot by the blood thinner injection right now, the pain will be relieved. You know what? One more thing as well is that if you give strong painkiller like morphine, it will affect the respiratory rate and the oxygen as well. and the patient is already having a very bad shortness of breath. So he will worsen the breath. You know, morphine has some adverse effects on the breathing. You will definitely do the troponin. Guys, the routine bloods, as we said yesterday, in NHS pain, again, full blood count, liver and kidney function test, and liver and kidney function test, and thyroid function test, and the blood cholesterol. And for any chest pain, please do not forget to do the cardiac enzymes. And EBG as well, Dr. Zaid. Thank you. Okay. Why EBG? Because the patient is having shortness of breath and you are worried about respiratory failure. All right. So again, can someone, no painkiller, Dr. Islam. No painkiller here. Do not give painkiller in this station. You do not know what the painkiller will do with the respiration. She's already shortness of breath. And as well, the pain is due to the clot itself, which can be dissolved by the blood thinner injection. Okay? Further treatment with the blood thinners will be needed to prevent other clots because the risk of formation of other clots is high. Okay? Okay. So anyone has any questions so far? I hope it was clear, but by the way, this station is one of the challenging. You know why it's challenging? Because the only clue to diagnose the pulmonary embolism is the risk factors. Pulmonary embolism usually is diagnosed by
I have a question.
Yeah, sure.
Okay. You have mentioned that I have to give ABG and cardiac enzymes. Do I need to give this initially or later?
Well, you know, Dr. Mahdi, you will ask them. You will ask them. I mean, you will control. You will take sample from them, but the results will come later. And this is one of the reasons that you need to keep the patient in the hospital. Did you get my point? Hello?
Yes. Thank you. Yes.
I mean, am I clear? Because I think the voice was interrupting.
Yes, it's clear.
Guess what? I think you're busy. Anyway, tell me. So my voice is clear, guys, or it's interrupting? If it's interrupting at any point, let me know, guys, because I think there's a problem with my connection today. Okay? Okay, so that's why the recording or the session will be recorded today. Okay, guys, so yeah, ABG will not show acidosis of tulamia. You need only to do the ABG because any respiratory problem, any shortness of breath or bad shortness of breath, you need to do the ABG to assess if there is respiratory depression or any respiratory, any electrolyte problem due to the respiratory problem. Okay, so please always mention the ABG in any respiratory or any shortness of breath complaint. Mention it, and it will not show anything, but just mention it. Okay, because in some cases you're not sure. In some cases we do not know yet. Actually, it can happen at any time. Any patient can come with respiratory failure, acute respiratory failure due to pulmonary embolism, due to chest infection, due to maybe overdose. So please make sure that you mention the ABG at any time. Do not talk about side effects because you will barely have time to say the blood thinner. You know, this is just a few injections of the blood thinner that you're going to give right now in the A&E. So do not talk about it right now. You can talk about side effects of something when you are in GP or you are in medicine department. Okay? Usually you will have time to talk about everything with the patient, but now you are just managing the patient emergently. So now you do not bother about side effects. For example, risk of bleeding is much lower than the risk of dying from the pulmonary embolism right now. And remember the sentence, please. Memorize it because you will use it later in one station. The risk of bleeding is far lower than the risk of the pulmonary or respiratory depression.
Dr.
Okay.
Ahmed?
Yeah.
Hello. Dr. Ahmed, in my case, when I took the name of ECG and chest X-ray and initial blood test, so examiner gave me the ECG finding of sinus tachycardia because in vitals heart rate was 100. Okay, so in ECG finding he gave me sinus tachycardia. In chest X-ray he said chest X-ray report is on hold. So then, what should I answer at that time? Should I answer anything at that time or in the middle?
What did he say about chest X-ray? Sorry, excuse me.
Chest X-ray report is on hold. Awaited means awaited.
Okay, you do not need the chest X-ray here.
In ECG.
Yeah,
Or
yeah.
in P.
Excuse me?
In P acute presentation A&E, when I said that I will do ECG, heart tracing for you, chest X-ray, initial blood test. So examiner gave me the response that ECG shows sinus tachycardia, chest X-ray report is awaited, and in vitals heart rate given 100 per minute. So
what about the oxygen? What about the oxygen?
Oxygen saturation 90. So initially I gave oxygen, and after that patient said, I'm feeling better. I'm okay to talk.
Okay, this is perfect. So what is the problem here? The problem is that actually, by the way, this lady was having mastectomy a few days ago.
I missed it. I missed in the history data gathering.
Yeah, because you know, if you asked about the mastectomy, you would know that this patient is usually at risk of developing the pulmonary embolism. And by the way, the station you are asking about is the differential diagnosis station. It is not confirmed to be ACS. We would discuss it right now. Okay, we discuss it right now. This is one of the stations included if you see the today list.
Okay.
Okay.
Thank you.
Okay, so I think someone was asking about the issue with the internet. I'm sorry, I missed it on the WhatsApp because this is a problem. Dr. Ofudili. Dr. Ofudili, can you hear me? Dr. Ofudili is not here, I think. Dr. Ofudili needs the recording and she's not here. Okay.
Dr. Ahmed.
Yeah.
Sorry to interrupt.
No,
just a request. It will help if, like, you know, you are teaching us the topics like PE, for example. So is it like, I think it will help if you could please like give us the scenarios that have come in the exam.
Okay.
You know, so that we kind of we can then practice them ourselves. You know.
Sure. You mean the task itself?
Yes, exactly. The tasks, exactly. So not the full script, but just the task. Like, you know, what was the task that came in the exam? Like, you know, for PE, this tasks came, or for like ACS, this tasks came. So it will kind of, I think, we will get oriented for the exam as well.
Okay, that's perfect. But this is a very good point, actually. But the only bad point, you know, Doctor, or the only drawback of what you're saying is that the tasks change. For example, the PE station changes sometimes from GP, some other times come in the A&E, some other times it comes at differential diagnosis, and the task is not fixed. But I will tell you about the task right now about each and every station. No problem at all. Thank you, Dr. Murad, for this suggestion. Dr. Ella, just say, I will give you blood thinner injection. Just say that. Do not say in the tummy, do not say where, because yeah, it's usually given in the tummy, mostly. And it can be given in the shoulder as well. But just say blood thinner injection. Don't say, I will give you injection in the tummy. You know, we do not specify which route of injection in PLAB 2 except for the IV fluids or the IV antibiotics. Okay? Okay, so let's speak about the other station, which is the differential diagnosis of the chest pain. Usually, this station, guys, is the problem. The only problem is that some people may be confused about it. Why? Because there is no clue to the diagnosis in this station. Okay. The thing is that here your problem is that you are in A&E. And the patient is female patient and she was having shortness of breath in 3 days. Same vitals and same everything as the previous station. By the way, if the patient shows you that she is having shortness of breath, like bad shortness of breath in the beginning, what you will do, Dr. Bina? Dr. Bina.
Hello.
Yeah.
I'm really sorry about that. Are you comfortable to talk?
No, doctor. I'm having shortness of breath. I can't manage.
Would you like me to give you oxygen?
Okay, doctor, give me please.
Okay. I would like to give my patient oxygen.
Okay. Why didn't you ask about the smoker cough?
Oh, yeah. We need to rule out smoker stuff. Yes.
Oh, this is a mistake. So you need always to rule out the smoker cough, Dr. Bina. Otherwise, you are in trouble.
Okay.
And you will see this in some men, okay? Give me 1 minute,
Okay.
guys. I'm sorry, give me 1 minute. Sorry for interruption. So, Dr. Bina, would you reconsider always saying or asking about smoker cough in case you're giving oxygen, Dr. Bina?
Oh, yes.
What if you forget?
Um.
5 pounds fine.
Okay.
Okay, no compromise.
Okay.
Okay, so you will find that the patient is having shortness of breath, which started 2 days ago, and you already treated the shortness of breath by giving oxygen. Shortness of breath and chest pain, the same elaboration as the previous patient as well. They're very similar, but there could be a little bit difference. The only difference is that the chest pain here is below the left breast, and with bad shortness of breath. Usually, the chest pain, guys, what is the character of the chest pain? The character of the chest pain actually is usually stabbing pain. So the chest pain is always or usually stabbing pain. Okay? Okay. And the pain actually it increases maybe with physical activity. Do you have any other symptom? She will tell you yes, this patient is having cough as well. As I told you, elaborate the cough. Your differential, the cough here is nothing conclusive, and the differential diagnosis are very similar to the past patient very well. And when it comes to the past medical history, here comes problem. Here comes a problem. See, this is very similar stage. Yet the people confuse it with the other scenarios. Why? Because people are, I'm sorry, scripted. Here the patient will give you no positive finding except that she was having breast cancer 2 years ago and it was surgically removed. So this is recent history of breast cancer, recent history of cancer. Isn't this enough? This is very enough. So the breast cancer thing actually is the only diversion in this scenario. Please point out the scenarios and point out the risk factor. Mind the difference between the scenarios, not the scenario itself. I mean, when you are studying, point out the difference, please. Differential diagnoses are very similar. The patient could be having hypertension here. So this is another difference. This patient could be having hypertension. Okay? Okay. She told you that she was having breast cancer and she had surgery for it. Okay? And this lady, actually, she could be having hypertension. But usually she does not take any contraceptive pills. So the only difference is here, no contraceptive pills, but there is breast cancer history. She's a smoker and she drinks alcohol socially and she could be having stress. Other findings are not conclusive. The travel history and the job and these things. So the only positive finding here is breast cancer and surgery. Aren't they enough to diagnose pulmonary embolism? Beside having shortness of breath for 3 days and cough and no fever and no other finding, I think they are very enough. So, yet here the examiner will be generous to you and they will ask you, doctor, what are your differential diagnoses? Actually, by the way, when you verbalize the examinations, the examiner will not give you any finding. But the examiner will ask you, doctor, what's your differential diagnosis? You will tell him that my differential diagnosis is number 1, pulmonary embolism. Very important. Why pulmonary embolism? Because actually the patient is having shortness of breath and chest pain, which started with shortness of breath, and the patient is having history of malignancy. This is very important. What will you do, doctor? As we said, number 1, admission. Number 2, senior review. Number 3, investigations. Like what? ECG and chest X-ray and routine bloods, including cardiac enzymes. Then we will start here on blood thinner injection. Okay, and after the blood thinner injection, actually we will send here to specialists to perform CTPA. Okay, the CTPA, if it's confirmed, the blood thinner to be continued in 5 or 7 more days. So here, please, the patient, or if the examiner asks you, what is your plan of management? Again, we will start the blood thinner. We will send for CTPA by specialist. After CTPA is confirmed, we will continue the blood thinner for a few days, and we will put the patient on blood thinner tablets for 3 months. This is similar to the PAT station very much. Why it's confusing? Because still, sometimes the examiner may ask you, doctor, what could be the other diagnosis? But this really happens. It happened maybe a few times, and it happened actually one of my lucky friends. He got it in his day. The examiner asked him what could be else. So simply, guys, if you are confused, it's very easy. And by the way, they are changing it, but to the easier way. What is the easier way? Is that you do not need to confuse yourself between the pulmonary embolism and the ACS. You just say that it could be also acute coronary syndrome. Why do you think so? Because the patient is having SOB and she was having chest pain. This is very simple. Just say that. And sometimes when you are saying the examination, you have to ask about the BMI as well. Because if she is obese, you can mention it in the ACS. For example, you can say that the patient is suspected to be having ACS as well because of shortness of breath and cough and obesity. And hypertension, definitely. So here your two differentials are PE and ACS. But most probably it is PE only. Wait, Dr. Saba, I'm just trying to, and hypertension, yes, Dr. Saba. So this station is quite similar to the past one, yet it came first in December. So you need at least to know what is the difference between the PE and the ACS. So 3 differences between the PE and the ACS in 1 minute. In 1 minute, I need you to be able, I have a good idea, very good idea. I need someone who's courage enough to come to me and I will tell him some few findings and he will tell me what is the probable diagnosis for them. Who can volunteer right now? I need only 1 minute because I need to be faster in the next stations. Who can volunteer?
I can do that.
Who is speaking?
Yes, I can.
Okay, Dr.
Brother.
Mahdi. Okay.
Speaking.
Huh?
Yeah, Dr. Mahdi.
Yes.
Okay, Dr. Mahdi, it's Dr. Mahdi's turn. It's fine. You will come later. Don't worry. So, Dr. Mahdi, I'm going to give you some few findings, and you tell me what is the diagnosis. Okay?
Yes. Yes.
Okay, I'm having chest pain, which lasted for a few minutes. Okay, and it was very severe pain. It lasted for at least 20 minutes. It was very severe pain. It was radiating to my left arm and my jaw as well. And it was not relieved by rest, and it was not elicited by physical activity. And I tried some painkillers for it, but it did not go at all. It just went away on its own. So what could be the diagnosis here?
Yes.
Okay, different. Perfect.
Yes.
Okay, Dr. Mahdi, that's right. So, thank you. So, Dr. Mahdi, one more thing. Dr. Mahdi, I'm having this central chest pain, which sounds like stabbing, and it started together with shortness of breath 2 days ago. And this chest pain actually is not going anywhere else, but it is aggravated sometimes by physical activity and some other times when I'm coughing. So, what do you think?
It's pulmonary embolism.
Perfect. Especially if I'm having history of family history or any history of using pills, or definitely,
Surgery.
yes, surgery or malignancy, right?
Yes. Yes.
Dr. Mahdi, what if I'm having this chest pain which started maybe 4 or 5 days ago and it's getting worse? And when you ask me about all the differentials, they are negative. All differentials are negative. I do not have any fever. I do not have anything, any trauma, nor anything. But I noticed something strange on my chest, like some rash on my chest.
This could be shingles.
Definitely. That's right. Dr. Mahdi, what if I'm having this chest pain which started like maybe 2 or 3 weeks ago and it comes and goes? Each episode lasts for 10 minutes only and it's coming or it's aggravated by physical activity and it's relieved by rest. And especially when I'm riding or when I'm walking my dog, sorry, and when I'm doing any jogging, it comes and it disappears right after I rest. What could be the diagnosis?
Okay. It could be angina.
Definitely, that's right. Dr. Mahdi, one last thing. Dr. Mahdi, I have this bad chest pain. I cannot even talk to you. It increases in breathing, Dr. Mahdi, especially when I'm taking deep breath. And it started maybe 3 or 4 days ago, and it does not improve even on painkillers. And it's getting worse when I'm trying to take deep breath or when I'm trying to do any movement by my body. And when you ask me about anything, I tell you everything is negative, but I have noticed that I fell off the bike 2 or 3 days ago.
Okay, actually I can't get you totally because of some issue, but most likely this is pericarditis.
No, that's not true. This is chest trauma because I fell off the bike 2 days ago.
Costochondritis.
Yes, costochondritis.
Okay, yes,
no problem.
yes.
Okay.
I'm sorry, actually I can't get you.
No problem at all. No problem. No problem. Okay, so one last thing. What if I'm having this chest pain, which sounds like burning sensation in the chest? It's not chest pain. It's just discomfort. Sounds like burning sensation, and usually comes after heavy meal.
GERD.
GERD, definitely. That's true. So one last question. I was just thinking about it. It appeared from my mind. Yeah, what if I'm having this chest discomfort, which sounds like fluttering sensation, like I feel that my heart is racing, and it comes with a physical activity, and it disappears by rest. And no, it comes in
Atrial
episodes.
fibrillation.
Do not say atrial fibrillation. Just do not say it unless the examiner gives you ECG for the atrial fibrillation. Just say arrhythmia. Okay? Say arrhythmia because other arrhythmias as well can come in episodes. So just say arrhythmia. That's right. So thank you, Dr. Mahdi and Dr. Nasib, for elaborating this. I hope now we are able to tackle any station of chest pain because this is how they change it. This is how really, no, really, this is how they change it. I mean, they can change it in a very manipulative way. They can change it in they can change it in a very smart way. But once you know the findings or the clues that you need to pick from each station, this is very enough to tackle any scenario. All right.
One question, please, Dr. Ahmed.
Yes.
Do we do Wells score before proceeding to investigation?
This is what I said in the beginning. Well, the good thing is that here, in most of the cases, you will not need to do the Wells score. You know why? Because actually the patient is usually moderate to high risk. From the history, you will get at least as the patient is moderate to high risk. Otherwise, they will not bring it to you. Okay? The patient is usually moderate to high risk. That's why you will go directly for the CTPA. For example, I will tell you, the patient here is having history of malignancy. This will give her 1.5. And the patient is having symptoms suggestive of pulmonary embolism. This will give her 3. So the total score here is 4.5. This is moderate to high risk, which needs CTPA. Did you get my point?
Yes.
So usually you will go for CTPA. Do not worry about that. D-dimer is suggestive, but CTPA, I mean when you are confused. But here you have a good clue to suspect the pulmonary embolism. How to rule out smoker cough? Simply ask the patient, do you have any smoker cough? Okay. So I hope this was clear, the past 2 stations. They are quite easy, but they are confusing, and that's why we spent a little bit longer time in them. We will not spend any longer time in the next ones. Okay? So let's move to the one of the stations which came recently. It's not so recent actually. It's just maybe it came recent. It came first in November, but it's a very easy station. They wrote it just to confuse all of us. We are thankful for this. We don't have any problem because we know how to clue or how to pick up any clue for any station. I just was discussing it with Dr. Mahdi. I was telling him that I'm having chest pain, which started a few days ago, if I'm not mistaken. And this chest pain is getting worse actually. But and when you ask me about any differentials, they are all negative. Excuse me, I didn't see it. So in the pulmonary embolism, the chest pain does not radiate. Yes, the chest pain is not radiating in the PE, Dr. Yemi. In the ACS, listen, Dr. Yemi. If you are confused, always remember that the nerve supply to the heart muscle, is the similar nerve supply to the lower arm, to the left arm and the jaw as well. And that's why the pain is always radiated to these parts when it comes to the heart. But in the lung, which is pulmonary embolism, usually it is localized to the lung. In very rare cases, it can be referred to the back, but not in all the cases. So usually this is what we call the typical chest pain, when it radiates to the left side and to the jaw. But in the pulmonary embolism, because it is in the lung, it's not radiated. Only in the heart it is radiated. Got my point, Dr. Yemi? Dr. Yemi, this is useful for you in your emergency. I know that you are having emergency shift.
Thank you.
You're welcome, man. So
thank you so much for coming.
You're welcome. So in the next station, this is shingles. Okay, I'm telling you that I'm having chest pain, and I'm having nothing else. Can you imagine this guy is only presented with chest pain? This is the only presentation. So what you are going to do? You are going to elaborate the chest pain. This is number one. Number two, very important to ask anything else. In this station, it's very important to ask anything else. And bad surprise, the patient will tell you, no, doctor, I'm absolutely fine. Okay?
Excuse me, brother, could you please repeat what you just said?
Okay.
After the chest pain.
Okay, good. So, Dr. Masih, you will ask him, do you have anything else? He will tell you, no, doctor, I do not have anything else. You are in trouble right now because the chest pain, he will give you, for example, the chest pain which started a few days back and it's getting worse on physical activity and it is dull pain, just dull pain. Or like sometimes if the simulator is good guy, he will tell you it sounds like a burning sensation. By the way, it is in the right side and the lower right side of the chest. So the chest pain here is on the lower right side of the chest. So definitely this is not GERD. Right? Right. So the guy here is telling you about these things. He's telling you that this chest pain is increasing on physical activity, and there is nothing specific in this chest pain. It's just dull aching pain. What are you going to do to this guy? You're going to ask him any other thing. He will tell you like what, doctor? Ask him, do you have any fever? No. Do you have any cough? No. Any difficulty in breathing? No. Have you injured your chest? Okay. What about my voice right now, guys? My voice is clear now? Everyone can listen to my voice?
Brother, it is breaking in between sometimes.
Oh, okay. Thank you for telling me.
It goes up and down, so sometimes it's good, other times you are very far.
Okay. So I'm sorry. It's just for today. Just bear with me because today I'm having connection issues today. So that's why I'm recording this session right now, and you can listen to it after our course is done or even in the next few days, inshallah.
Now it's very good.
Okay. So guys, please do not wait till someone asks. If you notice that the voice is breaking right on the chat, the voice is breaking. Because I need all of you to listen, not only one person. Okay? So the patient actually will tell you, no. So what are the differentials for the chest pain? You ask it about the cough, you ask it about the fever, you ask it about shortness of breath, you ask it about other things as well, like maybe nausea, vomiting, They are all negative. Okay, what about any swelling in the calf? He will tell you, no, doctor, no swelling in the calf or no swelling in the leg. So this patient is making it like difficult for you. Why he is making it difficult? Because he does not have any symptoms to you. Why don't you use your smart here, your smart way? Ask him, do you have any idea what could be the cause of your chest pain? Or have you noticed anything strange recently which can bring your chest pain? This question is very tricky and I like it because this will give you the diagnosis here. So if you are writing a note right now, write, please, if you find nothing conclusive in the presenting complaint, always ask about the idea. Do you have any idea what could have brought this chest pain to you? Have you noticed anything strange which could have brought this chest pain to you? Okay? Always ask this question. And guess what? This guy will tell you this question. I noticed that there is some skin lesions on my chest. See? Okay, Dr. Yemi, again. The question is, do you have any idea what could have brought this chest pain? Or can you think of anything strange which could have brought this chest pain? Can you think of anything which could be the reason of your chest pain? He will tell you, yes, doctor, I have noticed a rash. Oh, this rash is a cause of the chest pain here. Okay, ask about the rash. How do we elaborate the rash? Usually we say that any skin problem, we ask about site, we ask about the size and the shape, we ask about the color as well. This is rash, so definitely do not ask about any bleeding or ulceration. This is just simple rash. So just ask about any change in the color or any change in the size, very enough. So size, color, shape, those are a skin lesions. And if it's painful or not. Sometimes it can be painful, by the way, because the chest pain sounds like burning sensation. And usually, you know that the herpes zoster is associated with sometimes neuralgia, especially when it comes for a long time, because it's destroyed the nerves. And sorry, it affects the nerves, it irritates the nerve. When something irritates the nerves, it causes neuralgia. Yeah, exactly, Dr. Ella. So, now you know that this patient is having this rash, skin rash, right? Okay. Now you know that this is an infection. This is a bad infection. Herpes zoster is like a viral infection. When it is prolonged, it can cause some complications, right? Okay. Whose patient who is upset? Sorry? Who is asking this one? Dr. Ella. Yes. Your patient was upset because he could not play golf. Oh, that's bad. You can just validate it like, I can imagine how it can be frustrating. We will definitely sort it out for you. Please do not worry. Okay, I have a good idea. Why don't we spare the questions till after each station? For example, write down the questions that you need so that I'm going to ask them all after the station. I mean the elaboration of the station itself. Okay, Dr. Fudley, okay, one last question that you're asking. To do systemic review if the patient is not forthcoming with differentials for chest pain. ICE technique is the most important because you need to save time. In PLAB 2, you are bound by time, Dr. Fudley. This is a problem. If you are doing systemic review, actually, it would take you a long time. So it's much better if you do ICE to save your time. And by the way, simulator is willing to help. Just ask about his idea. So ask him right now, this is a viral infection, right? Ask him about, did you develop any fever? You asked about fever, he said no. Ask him, did you, now you know that it is infection, so please try to rule out the complications of the red flags of the herpes zoster, which could be meningitis. Always ask about meningitis as a complication of any viral infection, okay? It can happen, especially after herpes zoster, and also encephalitis. So simply ask about any headache, any neck stiffness. Okay, so the differential diagnosis here are as we mentioned them. But after the patient tells you that he is having rash on the chest, now you know that it's most probably herpes zoster. So you need to rule out the complications of the herpes zoster, the red flags of the herpes zoster, which are meningitis. Number two, herpes zoster ophthalmicus. What is herpes zoster ophthalmicus? Which you can simply ask him, have you had any shingles on your face or around your eyes? Because this is one of the complications of the herpes zoster. This is the two red flags for the herpes zoster. Now ask him about the PMH. What is the PMH here? Very simple.
Excuse me, brother. Brother, what was the question for herpes zoster ophthalmicus?
Any shingles or any skin lesion on your face or around your eye.
Okay, buddy. Okay.
Was it clear or not?
Yes, brother. Yes.
Okay. So now move to the past medical history. In the past medical history, simply you would ask about any recent infection and previous episodes as well. So previous episodes and recent infection. Those are the most important things. And ask about any medical condition. As we said, always do not miss this question unless after asking about diabetes and hypertension, because those are the two diseases which compromise the immunity. Herpes zoster can activate after lower immunity, so always ask about the diabetes. Ask about medications and allergy as well. I mean, you will take the whole PMH, but focus on three things. Number one, previous episodes. Number two, recent infection. Number three, family history or same complaint in close contacts. Remember, this is skin lesion, so always ask about the close contacts. Maybe he has got it from them, right? Now move to the lifestyle. Smoking is enough here. You can also ask about physical activity. Maybe he is playing sport and he's changing his clothes with someone. Okay, as a differential. Ask also about, as you said, the NHS pain affection or NHS pain station. Always ask about the job and travel history as well.
Can you repeat the lifestyle questions, please?
You will ask about the lifestyle as you wish, but just focus more. I mean, if you are running out of time, focus more on the smoking and the physical activity. Usually, the lifestyle questions you can ask all of them in any station, but just if you are willing to save your time, focus more on the smoking and physical activity in this station. Oh, one more thing. Actually, alcohol as well. Alcohol can compromise, or binge drinking sometimes can compromise them. So you may need to ask about the alcohol as well. So simply lifestyle questions will take you only 10 seconds. In general, do you smoke? Do you drink alcohol? Are you physically active? Tell me about your diet. Just 10 seconds. So here comes the examination. In the examination, you will say the examinations like the vitals, general physical, and chest examination. When you say chest examination, the examiner will show you a picture which showing a rash. I will post to you a photo of the herpes zoster on the WhatsApp group in a while. It's simply a rash which happens on the lower side of the chest, most probably in this case below the nipple. Okay? One important thing here not to miss is that when you are looking at any picture in PLAB 2, excuse yourself from the patient. Excuse me, I'm going to look at it. Now have a look at the photo and then back to the patient. Thank you for bearing with me. You will do the initial investigations. Which investigations? Bloods and chest X-ray and ECG. No matter what I do these investigations, please, in any case, as a safe doctor for any chest pain. Now we disclose you're having a condition we call shingles. What is this, doctor? Okay, shingles is a viral infection due of the nerve cells. Okay, it happens usually due to a virus called varicella zoster. So it is a nerve infection, or it is a viral infection to the nerve cells in different parts of the body, secondary to a virus called varicella zoster. Usually it happens due to weakened immunity or on top or after simple infections. Like what? Like flu, sometimes like chickenpox, sometimes. So, viral infection, which affect the nerves and happens after weakened immunity, especially after maybe latent or maybe after simple infection, like the chickenpox or even sometimes after flu-like symptoms. What is going to happen? Okay, in this patient, you know what to do. In this patient, you need to put him on antiviral medication, at least for 1 week. Okay, antiviral medication at least for 1 week. Why? Because this herpes zoster, it needs treatment, otherwise it can cause some complications. So you will give him antiviral medication for 1 week, and you will give him some painkillers because he's having chest pain. So you treat right now the pain, which is symptomatic treatment, and you will give him antiviral, which is definitive treatment. Okay. But one important thing, before giving the antiviral medications in this station and in the viral encephalitis, if you remember, we will discuss it. In any station which you will give IV antibiotics or IV antivirus, please consult with your senior. Please consult with your senior. Then the patient will tell you, should I look for anything? Ask him, may I know what's your concern? He will tell you, doctor, yes, because my son is coming to visit me and with my grandchildren. So this guy is telling you that he's going to receive guests. Some of them are children. So you need to advise him about staying far from the close contacts, from especially the immunocompromised people, like the extremities of age, the very elder people or the elder people and the children. Number 2, the pregnant people, the pregnant women. Okay, people who have not had chickenpox before. So those are the immunocompromised people. Again, pregnant and children and the people who did not receive the chickenpox or were not infected with chickenpox before. And a few more advices. You will advise him not to scratch the rash, not to put any cream or topical antibiotics over it because this can irritate it. Okay? If the rash is crusting, cover it. While if it is raw, if it's dry, you can leave it. So why I hide it or why I cover it if it's crusted? Because if it's crusted, actually in this case, it can catch an infection from the air. So better to hide it. Okay? Okay, so if it is dry, you can keep it open. And if it is crusted, actually you can or you should better hide it. And you would advise him, please try to wear loose fitting clothes. Why I use loose fitting clothes? To avoid any irritation with the rash. Any skin rash, you wear loose fitting clothes to avoid any further irritation. And stay off work. You'll advise him to stay off work. Okay? Okay. But the thing is that actually, if the rash is dry, you can go back to work. We said the painkillers will be given in the beginning. Dr. Ella, I said that treatment starts with symptomatic painkillers and definitive antiviral after consulting with senior. And then comes the lifestyle advices, like avoid contact with the people who are immunocompromised. Keep the rash covered, especially if it's crusted. But if it is dried, you can wear loose fitting clothes and keep the rash open, no problem. Do not apply any further antibiotics or creams because they will irritate the rash. Stay off work. Stay off work and only go back to work when the rash is dry. Why? Because if the rash is crusted, unfortunately, it can infect other people by contact with them. So please stay off work at least till the rash is dry. Do not specify any period because it differs from one person to another. Okay? So we said that the antiviral medications will be given for 1 week. They are oral antivirus, not IV, but the oral antiviral because it's long course of treatment oral antiviral, it needs some senior review. You will follow up him after 1 week. He will come back to you after 1 week, okay? So you will tell him that we need to see you back in 1 week to see how we are improving and you are complying with the treatment. So again, to sum it up, the patient having chest pain together with rash, evaluate the chest pain, rule out all the differentials, they are negative. Only there is a rash, and this rash is characteristic for the herpes zoster. It is painful, it is not itchy, and no, it can be itchy sometimes. It is painful and it can sometimes be itchy, and it is in the lower chest, and it's very obvious to be herpes zoster because he will tell you that it sounds like burning sensation. Okay, complications of herpes zoster, meningitis. Do not forget herpes zoster ophthalmicus, any shingles or any skin lesions around your eyes. Past medical history, very important to ask about previous episodes and infection, any respiratory infection or flu-like illness, any medical condition. We will speak about this, Dr. Yasmin, sorry. The thing is that actually here in this case, you have to ask about diabetes as well, because I think sometimes the patient can be diabetic. I mean, they can change it from chickenpox or from, sorry, flu-like illness he was having to he's having diabetes, as far as I remember from the scripts. So medications and ask about family history or close contact. Lifestyle is very relevant here. Do not forget to ask about job and social history. Examination. The examination is the core. You have to always mention chest examination so the examiner will give you photo of the chest. Investigations, as we said, disclosure and explanation and treatment. Treatment, keep in the hospital, okay, right now, because we need to assess him. Number 2, give painkillers, symptomatic. Number 3, definitive, is antiviral after consulting with senior. Then give general advices to him about how to avoid people and how to act with the rash. And we will see him back in 1 week from now. Okay?
Brother, are we going to admit the patient here?
Yeah, you go to.
For how long?
Just say we need to keep you in the hospital to have a closer look at you. Why? Because this is one of the complications. I mean, sorry, because the complications of the herpes zoster, it can occur at any time, and he's having this problem since 1 week. So better to keep him in the hospital. Okay.
All right.
Keep him here, and after keeping him in the hospital, you will start your maybe you will start your painkiller, and after that you will start your antiviral medication. Okay. What if the setting is the GP? What if the setting is GP? Okay.
Dr. Ahmed, is there any need for steroid?
Excuse me?
Is there any need for steroid?
No. Don't do this. Don't do this here.
All right, thank you.
Okay. If the patient is in GP, so definitely you will not tell him that we're going to keep you in the hospital. So you will just give him the medications. Yes, exactly. To charge with precautions, which means that you will give him the medications, the normal treatment, and after that you will send him home and come back in 1 week. Okay. So if you know now that he's in GP, if he's in GP, you do not need to keep him in the hospital. Usually he comes in GP because he is having the chest pain since 4 or 5 days. But he just came here because it's increasing. Okay. So this is the station so far. Doctor, who's asking about the steroids? Actually, the steroids, you do not give the steroids in herpes zoster because sometimes it can also like affect or lower the immunity as well. So you do not need to worsen the problem. This guy is already immunocompromised. Okay, so herpes zoster is simply by antiviral medication to treat the or to deal with the latent virus, which is the varicella zoster, and as well the painkillers because the pain is really bad. What painkillers, Dr. Yasmin? It differs. We give usually the gabapentin or the amitriptyline. We give them for the neuropathic pain. But you know, they are better given for the post-herpetic neuralgia. I mean, when this pain is worsened. So they are not given initially. We just start with a normal painkiller. You can just say simply, we're going to give you painkiller. Very simple. If the patient tells you which painkiller, you can say we are going to start simple painkillers. And if they do not respond, we are going to give you special type of painkillers for this type of pain. This station is quite easy, by the way. You pray that you get this station. The pass mark for it is very high. I think when it came to one of my friends, the pass mark was 7.5. It's very short. It does not need anything. Only one question can give you the diagnosis, which is the idea. Okay, ask about the idea of the patient. What do you think? Always have this habit. In case of any scenario changes, always ask the patient, do you have any idea what could be the reason? Or what could be the cause of your pain? Okay. Let's move to one more station. Right now, we are going to discuss the shift trauma. The shift trauma station is very easy station, yet I don't know why many people are confusing it and they are bothered about it. It came to me my first attempt, and I scored 10 in it with only one time reading. Why? This guy is quite straightforward. It's quite straightforward, and there's no
voice is breaking, brother, sometimes.
Okay, good that you told me. So this guy is quite straightforward. He is going to give you history of chest pain. Sorry, Dr. Rumi, you are FY2 in A&E. My patient is middle-aged male, like around maybe 30 or 30-something years old, and he is presented with chest pain. This is the only complaint. By the way, when you enter, you will find that the patient is lying on the couch. Can't hear, so still can't hear? Is there a problem with the voice so far? Oh, yes.
Sometimes it's going high, sometimes it's going low.
Yes, I told you because some problem.
It's not constant.
Okay, this is a problem with my connection, and that's why it may be recorded. No, it's recorded actually, and that's why it's recorded. Please, when someone is not able to hear, please tell me right away. Yeah, I know. It's a problem. It's a problem with my voice. I'm just going to record it. And for this session, actually, if you need to be repeated after the course days, I mean, if the recording is still not fine, I'm going to repeat it again because it is something out of my hands. I think someone is missing now. Dr. Samia, I think. Dr. Samia was here and she left. Okay, so for the chest pain, for the chest trauma station, the patient, the patient actually, what we do, the patient, when you enter the cubicle, you'll find that the patient is lying on the couch, which means that it is like, okay, it's chest pain. The patient is lying on the couch when you enter. This means that it is most probably examination station. So now we are speaking about the chest trauma station for the people who are confused. When you enter, you'll find the patient lying on the couch, which means that you may need to do examination, and actually it is combined station, which means that this examination station. So you'll find, and you'll enter, you will find actually a guy lying on the couch. He is like exposed from above his tummy. And this is another clue that this is an examination station. This is a clue that, no, actually the problem is not in the mic. The problem is in the connection itself, I told you. Okay. I'm just trying to improve the connection. Still, anyone has a problem with the voice so far? Give me 1 minute. Has anyone, Dr. Maria? Dr. Maria has just texted me and she said that she cannot join the meeting. What is the problem? Guys, can you hear me? Dr. Maria has been texting me and she said that she cannot join the meeting. Oh, I think she pressed on leave the meeting. That's why she could not join. Okay, so let's give a quick review about this station. In this station, simply, you'll find this guy lying on the couch, okay? And this guy is usually a sports guy. What means that? He's having good physique. You will enter and you will tell you, doctor, I'm having chest pain. He's showing you that really a chest pain is coming, or he is having very bad chest pain. When you elaborate the chest pain, you will find that this chest pain started maybe 2 or 3 days ago. It was a simple chest pain and it got worse. Okay? This is a simple chest pain, got worse on shortness of breath. And got worse on deep inspiration and gets worse also in movement. Nothing specific. But just remember that this is the only chest station or chest pain station which you need to perform examination. Okay? So to perform this examination, to remember this station simply, you will ask him after this, do you have anything else apart from this chest pain? He will tell you like what? Always ask about your DDs. Any fever, any cough, any shortness of breath. Okay, doctor, give me less than a minute, guys. I'm going to send this password to Dr. Maria. Wait, guys. Wait, I'm sorry. Okay, guys, we need to be a little. I may need to be a little bit faster in the next 2 hours and a half because we are still having many stations uncovered. We may need to cover all of them today. I'm sorry if I will go a little bit faster because they will be similar to each other. So we need to cover most of them before finishing today. We are not going into very deep and specific details. I'm going to give you each tips and tricks for each station. Not of course very superficial. I will give you like good knowledge and good things, but please, if you have any further questions, let it be after the session. We need to cover everything. We need to cover most of the stations, not most, all of the stations. We are still remaining, or we are left with at least 15 stations, and we need to cover them in 2 hours and a half, or even less than 2 hours and a half. So I will try my best to be a little bit faster. Okay, I'm stopping the session right now for Dr. I think Dr. Maria. Dr. Maria is having a problem. She's trying it and she's coming back. Okay. So in this station, simply, I'm going to start quickly. This patient is not having any symptom except for chest pain, which increases on breathing, and as well it increases on any physical activity or any simple movement. So this chest pain increases on activity and simple movement, guys. And he doesn't have any other problem, like no fever, no cough, no any other thing. So what else? What could be asked here, Dr. Masih? This patient is giving you nothing. Dr. Masih, what do you think? What do you think I could ask him here?
We can ask about the idea of the patient about the chest pain.
Perfect. That's what I did. I asked him this question. Actually, I did not know. I mean, I was not aware about it. I didn't know anything about it. I mean, just I told you I read it once and I was not even aware about it. I just, you know, it was just my exam night, and I was just asking, or I was just wondering about it, like quick read, giving it a very quick read, which was not like. Yeah, I think so. If someone is noting the questions in the end, it will be much easier for all of us. I'm ready to answer all questions, even if tomorrow I will spare 1 hour for them to ask all your questions, to answer all your questions. I mean, 1 hour before the session to answer all your questions. It's fine with me, but I just need you to be a little bit more faster. We need to be a little bit faster. People think that okay, I have to admit that I'm trying to cover as much as possible, but still, you have notes with you, and as well, you're having what I say. You're still having much time to do that. And my mission here is to pick up the important things for you. If I'm going to teach you, I know some academies which teach everything and they end up having 18 days course. So this is fair, and 18 days of 12 hours. No need to mention names, okay? Because we are recording. Actually, this is not reasonable. We need to finish as much as possible. All of you are having background about PLAB 2. All of you have read before. Not all of you, because Dr. Maria is starting, but at least this course will be a good vibe to her, or like a good push to her. And I provide you the approach, how to approach each and single station. By reading them one more time, you will get to know at least how to ask about things and how things really work. Okay, so let's be quick. You asked about the idea, Dr. Masih. Dr. Masih, he told you that I fell off the bike 2 days ago. Now you at least know that this guy is having chest trauma, right? This guy is giving you chest trauma, which happened 2 days ago. Now you will tell him when did it happen and how did it happen. Simply, he will tell you I fell off the bike on my right side. Okay, so basically this is a side in which he's having this pain, by the way. Okay, okay. Any other things are irrelevant. Any other things are irrelevant. So this guy is not having anything else. Okay, ask for your DDs. We asked about them. All of them really asked about them. Now ask about the past medical history, like any chest pain infection. Ask about lifestyle. When you ask him about smoking, he will give you a look. He will tell you smoking. Doctor, I'm physically active. I'm a triathlon player or whatever. Alcohol, he will tell you, welcome back, Dr. Maria. Alcohol, he will tell you, Doctor, I don't drink alcohol. I'm very physically active. I eat healthy, balanced diet. Now, please move to the important thing, which is the examination. In the examination, you will verbalize the vitals. You will verbalize as well the general physical examination, and you will verbalize the chest examination. Why chest examination? Because this is the core of this station. It is a combined or examination station which you need to examine the chest. People are confused about chest examination. I do not know why. It's very simple. You do the inspection. You tell the patient, I'm going to examine your chest. For the purpose of this examination, I need you to be uncovered above your tummy. I can see that you're adequately exposed. Thank you for that. I ensure your privacy and you'll be having a chaperone through the procedure. If you feel any discomfort at any point, please do let me know. Dr. Maria, we are in the chest trauma case. So you will tell him, if you have any discomfort at any point, please do let me know. Okay, so now you will examine the chest. You start by inspection. On inspection, you will comment saying that I can see there is no mass, no swelling, no mass, no swelling, no bruise here on the chest. Okay, chest movement is symmetrically bilateral. Sometimes he can show you that the right part of the chest is not moving well. Why? Because he cannot expand it. He's having pain. Verbalize what you can see. Always say it out loud. After inspection, do palpation. But here, the palpation, you have to do superficial palpation. How to do superficial palpation of the chest? You can simply do rolling movement. Do rolling movement like from the far side. For example, if he's giving you chest pain on the far right chest, you will start from the left side of the chest. Start from the area away from this pain. till you approach the pain site, and he will give you ouch. Oh, I'm so sorry for that. Would you like me to proceed? No, please don't. Now you will try to do the deep palpation, which is a chest expansion, by placing both your hands below his nipple and make a seal around the circumference of the chest. Ask the patient to take a deep breath. He will not be able to do this because it's very painful to take a deep breath. Then do percussion and auscultation. You will find nothing. Okay? Now move to the investigations. The investigations, you have to verbalize the initials at least, like ECG and chest X-ray and bloods. Why? I will tell you why. The examiner will ask you which investigations are. You will tell the bloods, including the bloods, of course, explain them like full blood count, liver and kidney function test, and heart enzymes, and chest X-ray and ECG. Why do you want to do this, doctor? The examiner will ask you. Because I need to rule out the emergency. Like what? I need to rule out some other emergencies like pneumothorax here in this case, and I need also to rule out any heart problem. He will tell you, okay, doctor, examinations and investigations are normal. But the blood test, but the heart enzymes or the cardiac enzymes are awaiting. So the initial investigations are normal. The only problem is that the heart enzymes are awaiting. So you will tell the patient, do you have any idea what's going on? He will tell you, doctor, what is this chest pain? What is this pain? You will tell him that it's a condition we call chest trauma or musculoskeletal pain. Why musculoskeletal pain, or what is this? It is a problem in which there is a problem, or it is a problem in which there is a pain due to like maybe strain of your muscles, overstrain of your muscles, especially the chest muscles in your case, and it happened due to the fall you had from your bike 2 days ago. Oh, doctor, so it's not because of my heart? It's not because of my heart, doctor? Hello?
Your voice disappeared. Can you repeat it again?
Okay. So you would say that he will
After
tell you,
disclosing.
okay, disclosing, you would say that it is chest pain, or sorry, it is musculoskeletal chest pain. Did you get it, Dr. Vina?
Yes, I did.
Okay, you will tell him that it is musculoskeletal chest pain. Okay, what is this, doctor? It is a pain because of some problem in the muscles of your chest, overstrain in the muscles of your chest, which happened due to the fall that you had. Oh, doctor, so it's not because of my heart? May I know why you think so? Because, doctor, I'm very worried about heart attack. You know what? This guy is worried about heart attack because his father has had heart attack and he died out of it. So reassure him, I'm really sorry for your experience. Please do not worry. We are all here to help and support you. Your symptoms are not suggestive of having any problem with the heart. However, we will still wait for the result of some investigations to confirm. Oh, doctor, but what can I do then? You will tell him that there are simple measures to follow, like any muscle problem. Painkiller, we will prescribe him some simple painkillers, and from the other side, he needs to do some general advice. Which general advice here? General advice here should be, number one, rest, but not full rest. Try to be a little bit active. Okay? Having said that, avoid strenuous physical activity, because strenuous physical activity can worsen this problem. He will tell you, doctor, but I'm having a triathlon in 2 weeks. I'm sorry, but you need to rest. You do not need to involve yourself in strenuous physical activity. It can even worsen your problem. Doctor, so wouldn't I be able to attend it? I'm sorry, but I'm sure you agree with me that your health comes first.
Can you repeat the advice again, please?
The general advice. The general advice is number one. You will advise him about the rest. I mean not full rest, like simple rest, and advise him to avoid any strenuous physical activity. Why strenuous physical activity? Because strenuous physical activity can worsen this problem and can put more strain on your muscle. So, doctor, wouldn't I be able to attend the triathlon? You will tell him, I'm afraid that it's not possible because you need to rest for at least a couple of weeks. Actually, it is 4 weeks. Oh, doctor, so what can I do right now? Here in this case, you tell them that I'm sure that you would agree with me that your health comes first. Because if this is worsened, you may not be able to go back to sports anymore. Okay? So, doctor, okay, doctor, I accept that. So, again, he should stay away. He should stay away from these things, from the sport. Guys, is there any problem with the voice? Any problem with the voice? Breaking again. Okay. So advice again, general advice like regarding the practice, like sport, and stay away from strenuous physical activity. And if he asks you, is it heart attack, you will tell him that it is not heart attack because of symptoms. However, to make sure we are still waiting for the results of your investigations. What could be the warning signs? The warning sign that you will give to this patient. Warning sign that you need to give to this patient if your pain is not eased upon rest and simple measures, please come back to us. Also, some other safety netting. You are going to tell the patient that to improve your recovery, you can try some simple measures, like what? Like trying to take a deep breath in and out from every now and then. For example,